welcome to this Give Me 15-Minute Education Program by SCG Health. My name is Jennifer Searfoss, and I'm the CEO of the Searfoss Consulting Group. To help you spell my last name, which I know is a doozy, we call the company SCG Health. We opened our doors in 2011, and we focus our client services on value improvement, revenue cycle management, and strategic planning in this post-health reform world. This session really gets to that strategic planning component. Since 2016, we also are a Medicare qualified clinical data registry. This presentation will cover everything that you should need to know, and if not, please email me about the Bipartisan Budget Act, which just came out. So you are getting this directly out of my brain. If there are any errors, I take full responsibility for those. This session and many others are available for free as a video archive on YouTube, and we do also have in-person conferences where we talk about coding, documentation, compliance, EMR implementation, value improvement, many other concepts. So if you're interested in any of those items, please check out scghealth.com. Now, one quick legal note. While I am an attorney, these are my opinions, these are my interpretation of federal law and some of the politics that are going on behind them. If you have any questions about what's being covered, especially on implementation, I am going to cover some stark aspects of it. Please contact your own counsel, your local counsel, and they should be a healthcare attorney because this is going to be getting into some gnarly areas. So with that, let's go ahead and get started. And so I'm going to start with a bit of an explanation about what the heck is a CR. As I go through this, you'll learn that what we talk about in Washington, D.C. Typically is going to have an acronym. If it doesn't have an acronym, we don't know what it is. So I apologize. You're going to have to go along with me on some of these new acronyms. So what's interesting about the current political climate, I'm sure you've seen numerous news articles covering this, is that typically Congress cannot get together and really agree on anything, and that has resulted in 2 government shutdowns this year. So just let's start off with some history here about the current funding that we're at. It started back in September, so on September 8th, right after Labor Day, was the first continuing resolution, and that pushed everything until Christmas. And members of Congress love being able to go home for the holidays. So typically putting something in December means that they have to act because they want to go home. Well, they didn't come up to a total agreement on how they wanted to fund the government, so they kicked the can down the road a little bit and put it right before Christmas. Again, trying to push that negotiation into that Christmas timeframe and get folks to go home. But instead of doing that, they passed something on the 21st and they went home until after Martin Luther King Jr.'s birthday and came back January 19th. Into the new year. And that's where we got into some interesting shutdowns. So the first one, funding went through January 19th, and they didn't come to a negotiation or standpoint until the 22nd. And then that expired on the 8th, and then the next morning, and I'll show you some of the times, and that has everything to do with politics, but that was passed on February 9th. So we are acting on the appropriations for the opening of the government departments, agencies, and programs. That is on a continuing resolution, which expires March 23rd, 2018. Now, I'm sure you're aware a lot of the debate that the continuing resolution has been tied up in has everything to do with DACA and immigration. And this is about the number of children that are here in the United States and very different issues than healthcare. So there's a lot of politics involved in this. But the point is that you do these little short-term appropriations bills called continuing resolutions until you can come to an agreement. And that agreement, if not reached, does result in the government shutdown. And as I said, we've already had 2 just this year alone in 2018. So this last continuing resolution was bundled in part of what I'm going to call, and what we fondly call on the up on the Hill, is a Christmas tree bill, because it includes everything under the sun. It is something that is leaving the station. It is a train going out. And because of that, you're going to put everything that you can into the bill. So it is basically, it starts out as a framework. It does include a continuing resolution until, as I said, March 23rd, 2018. So we've got a little bit of time here. But what's interesting to me and why I am so intrigued by this thing is that it does also include some other aspects. And so let me talk about this. So it includes the continuing resolution, which is going to fund the government until March 23rd. But basically, it sets out what they're going to pay for and what they're going to limit the spending for different departments, like Department of Defense and some big areas for the next this big CY 2018, but also CY 19. So it's a 2-year area that it's going to cover. It's going to be a question whether or not it fully goes into fiscal year 2019 or not. But it is going to be a rather large spending bill, and that's the plan, is that by March 23rd, they'll have that agreed to. It does also take off some very big negotiation points, and one of them is that it's going to suspend the debt limit until March 2019. So that's a really big one, because that's now off the table. So if it does that aspect, that means that honestly, that Medicare checks can go out, and there's certain things that are going to get paid, even though the debt ceiling has been hit. And because it includes some other mandatory spending vehicles, such as the debt limit, a number of negotiation tactics that we would have thought would have been on the table are not. So really, really interesting. So it outlines what they're going to do on the discretionary budget. And then it also does include some appropriations. Now, what are those appropriations? Those are for disaster recovery. So that is coming back from all of the hurricanes that happened in 2017, especially Puerto Rico. That's included. There's also some infrastructure, so some bridges and other aspects that are out there. Now, from healthcare, the two big ones we noted were that the opioid epidemic, it has funding in there for addressing that, and also it has funding to extend CHIP, the Children's Health Insurance Program. So some really big areas. But honestly, from my standpoint and where I geek out, it has a bunch of other program aspects in it. So that's what we're going to talk the majority about here in this session. So again, if you're a geek like me, you can go in and find Public Law 115123. There were the votes, and they were at 1 in the morning, so 1:30 in the morning and 5:30 in the morning. So very interesting time frames, and that had everything to do with Rand Paul wanting to talk about deficit spending on the floor, and he did. If you want to go download the full text, I'm going to quick show you those. You can. The full text is out there on congress.gov. That's the website that you are going to need to get to know. And it's an interesting website that we use a lot in my work. So I was going to show you those, but apparently I cannot. So let me see if I can get over here. 1 second while we do some technical changes on my system. There we go. Let's see. Nope, it's not going to show this other screen for you. So in the meantime, I will, let's see, I cannot get over there. So I will not show those to you, but it's on congress.gov. So that's a website that you can go and check out. Also, you can download the text, that full text in a PDF, and it is going to be several hundred pages long. So this is the quick version of it. So the table of contents just for healthcare does include 12 different titles. They did put them in sections, which is really helpful. And the two areas that I'm going to geek out on are going to be the Medicare extenders, because again, that's pretty much our bread and butter. And then something called the miscellaneous healthcare policies, because, you know, miscellaneous is always where important things are. So let's go ahead and walk through a number of these components. So the first thing I'm going to talk about, and this has gotten a number of phone calls just to our office this morning, is that in section 51003, there are some technical amendments to MACRA. And if you remember, MACRA has everything to do with implementing the merit-based incentive payment system and the alternative payment models that are out there for the future of how physicians are being reimbursed. So these technical amendments to MACRA are going to impact you for 2019, so starting next year. It will require there to be formal rulemaking, and there's actually a really interesting article that CMS is not prepared to deal with this right now. But let's go over one of those things. So the first thing is, if you are in an office such as an ophthalmologist or an oncologist, Part B drugs have been included is one of the items that the penalties could apply to. That's now been eliminated and pulled back. The other thing, too, is that there's been a lot of feedback and a lot of screaming from some other organizations, namely MedPAC, the Medicare Payment Advisory Commission, saying that MIFS is broken. And one of the areas of concern has been the cost component. So Congress stipulates to CMS that they need to slow the cost component down, and that they've capped it to 30% by 2022. Now, I will note that payments for CY 2019 for 2021 payments already has cost at 30%. So more than likely, this will require some rulemaking coming from CMS that will change the that cost component. It will either lower it or it could stage it over time. So I'd look for some changes coming out about that. Also, CMS is able to more gradually raise the threshold for total performance, and it goes out to 2024. Now, if you remember, and I had to actually go look this up, the performance threshold is actually that 4% to 5% cut, that was for 2017 and 2019 payments, and then 2018, since we're in 2018, your 2018 performance is on 2020 receipts, right? Yeah, so it's a 2-year lag, and it's a 5% positive or negative. So they can change those thresholds. They've been given that authority, and that was something that they asked for in the White House's CY 2019 budget proposal. So they did get that. That was included in the Bipartisan Budget Act of 2018. The last one is that the Physician-Focused Payment Model Technical Advisory Committee, also known as the PTAC, is able to now give some more feedback to CMS regarding the alternative payment models. So that's exciting that they've been given a little bit more authority. So that's the stuff right now that's been passed to tweak MACRA. The most notable one is going to be, again, those performance thresholds may be changed. Also, that cost has been pulled back a little bit. Those are the two big things to be looking for. And I'm going to give you some notes on when I'd anticipate those changes. Some changes about Stark. This is in section 5404. The first one is about signature requirement. So if you had something where you were out of compliance, you're now going to be given 90 consecutive calendar days to basically get the signatures on a compliant basically something that you were doing that was not compliant, you'll have now 90 consecutive calendar days to get that fixed. There's also about holdover leases and personal services releases or arrangements, and that's great that I can spell quickly. But the big thing is that you'll be given some opportunity with holdover leases. So long as they are compliant, they will allow you to continue to do the rollover. Now, quickly on Medicare extenders, for those of you that are in a geographic practice cost indices, one of those gypsy areas that had a floor that was not, that was going to get cut, they are going back for 2018 and 2019. So this is probably going to be a technical amendment that will be coming out soon from CMS. They've extended those geographic practice cost indices floors through the end of 2019. So that's good. For those of you that are doing physical therapy and occupational therapy, they've repealed the cap for services beginning January 1, 2018. So that's a really, really, really good thing. But they have gone back and the manual review process reviews. This is the big thing. So those audits, they've decreased it. So it's now 3,000 is going to be where you're going to start having the technical manual medical review process targeted audits. What I'll tell you on those is please make sure that you have all of the required and necessary documentation. In the audits that we've done, number one is that the physician order is not within the time period as required. It's not signed and dated within that time period. And then the second one is that the certain language noting that the specificity, the technical services that physical and occupational therapy provides and the requirement for that patient, it's not noted in there. So some opportunity for better documentation. The last thing is for those of us in the quality improvement organizations and all of our work, there's a 2-year extension of funding for groups that are developing measures. So that's another one that was interesting. $7.5 million are still out there to help develop those. For those of you that are involved in the CHIP program, this is probably one of the most political hot potatoes that was out there. So there's an additional 4 years of funding. So it's through fiscal year 27. So it's going to be for a while. The other thing too is that there are some pediatric quality measures that now do need to be reported by the states. So that one's going to be, I think, a big change for those of you that there may be some pass-through requirements that you're going to need to do now in pediatrics. One of the Christmas tree aspects of it is that there's a couple of bills that are bundled in here. The Chronic Care Act is one of them. So for Medicare Advantage plans that had special needs programs, those have been extended. So that was, I think, one of the really interesting things. The other thing, too, is that Medicare Advantage plans that are now moving into value-based insurance design, so basically moving to MIPS and alternative payment models, they are able to do that by 2020. So start looking for changes in contracts on that. And also they are allowing new supplemental benefits to come out from Medicare Advantage plans. That does include telehealth, but those should be targeted to the chronically ill. Some areas that I found interesting, so there's some expansion on telehealth for home dialysis and a couple of other areas, stroke as well. Also, ACOs are now going to be able to expand what they're doing in the telehealth areas. And then one of the ones that I found interesting, again, for Medicare ACOs, is that they can prospectively get their patients assigned. So that's something actually that we've been asking for, so it's going to be exciting to be able to have that, especially with chronic care beneficiaries. The last thing that I'm going to highlight here is sort of two reports that I found really interesting, so I'll be looking for these. One is a GAO, so the General Accountability Office report to Congress on the prevalence and effectiveness of medication synchronization programs, which I personally think the government and the industry has two different terms that they use for that. And then the other one is going to be for long-term cost drivers to Medicare. And again, I really think that that's going to be something that is really going to help us target where we work a number of our value and quality improvement programs. And then the last one here is Part D sponsors. If they want to get data going back on what drugs their beneficiaries have gotten in years prior, they'll be able to get that data. In the Part B Improvement Act, there is now a transition year or a bridge for anyone that's on the home infusion world. There was some expansion of the benefits starting in 2021, but nobody could get there. So it basically establishes the bridge so that they'll have some coverage for transition education services. And then also for dialysis providers, there's been a lot of discussion about those, including even a really interesting story that was done by John Oliver on HBO about dialysis providers. But they now have to go to accreditation, and so this allows them to get outside accreditation. Some other areas for speech-generating devices, there's some new requirements for that. It was sunsetted and it's now been expanded. One I found interesting, though, is for DME providers. They have to offer at least 50% of the diabetes test strip brands used by beneficiaries. They can't just choose a cheap diabetes test strip. They have to use the test strip. They have to use the name brand that the beneficiaries are using. To me, that sounds like a member of Congress getting some phone calls from their beneficiaries. So let's talk a little bit about this one. This one I found interesting. There was a health workforce demonstration project that was helping low-income individuals getting loans for education. So that has now been expanded and funded through fiscal year 2019 at the current funding level. So that one to me was exciting. And then a couple of other interesting ones. So again, we've talked a lot about this opioid epidemic. So it is $3 billion. It's a B, so we like Bs. If it is an M, it's budget dust. If it's $3 million, whatever. But it's $1 billion, so we'll pay attention to it. And it is effective for fiscal year 18, which we're in right now. So we'll see how that's going to happen. It's going to be through state grants, public prevention programs, and law enforcement activities. More than likely, this is going to be block grants, but we'll see how those go. Also, they are extending two programs that were for the special diabetes programs. For those of you that have started looking about participating in, it's an advanced alternative payment model in that diabetes program, there are going to be some additional funds that are available to you out there. Let's talk about one of the areas of interest. Shoot. Let's see if I can get rid of this. So one of the areas of interest for miscellaneous healthcare policies was in the IPAB. If you know what that is, this was also called one of the various concepts that was called a death panel by Sarah Palin. There's 3 policies that were sort of bundled into that statement, but this is one of the ones that was going to make recommendations on reducing Medicare spending. This honestly was duplicative to a lot of what MedPAC does, and everyone thought it was stupid, so it's now officially done. A number of members of Congress are really excited about this. And then also, it now is going to permit physician extenders to be able to either manage or bill for certain hospice and also cardiac and intensive cardiac programs. So that's exciting there that we'll have some new changes. But because this is not an appropriations bill, it has to pay for itself. So we call these Payfors or pay-as-you-go, but it has to include Payfors. So here's your downside on what's going to get some cuts. First off, if you remember that wonderful sequestration cut that you see on all of your payments, it's a 2% cut to all of your payments. That cut is extended until fiscal year 27. It also is going to reduce payment for outpatient PT and OT services that are furnished by a therapy assistant to 85% of the allowable. So it's kind of like a nurse practitioner or a PA, those same kind of cuts. And then it's going to cut the Medicare physician fee schedule update that was set to be 0.5%. It's now going to be 0.25% for the upcoming calendar year 2019. So that is how it is paying for some of these things. So a couple of highlights that I do want to let you know, because again, I've been getting some phone calls, is that the fiscal year 2019 budget for the president did come out from the White House. Basically, these things are called frameworks. They are dead on arrival to Congress. Basically, Congress is like, how dare you, White House, tell us what we need to do? This is our job. So go ahead and sing I'm Just a Bill from Schoolhouse Rock in your head, and remember that under the Constitution, any bills that have money, that is coming out of the government, an appropriations bill must start in the House. So it's going to start in the House of Representatives, then get signed by the Senate. It could go back and forth and go to a conference committee, but that's the process. And then it's signed by the president. The president is last on that chain. So whatever his priorities are, they can either be listened to or laughed at by Congress. Now, the proposal does include a number of things in there that I will say could affect how payments could begin in, more than likely, again, fiscal year 19 starts in October, so we're probably talking about calendar year 2020, which would be Medicare payments for 2021 if we think about the MIPS program. But I'm going to tell you that I'm thinking right now the final appropriations bill that's going to be negotiated in March may cover fiscal year 19. So this may be just completely dead on arrival and was just a waste of paper. We'll see how that goes, but March should be very telling. So circle March 23rd on your calendar. The other thing too is remember that rulemaking, no matter what, is still going to apply. So for a calendar year 19, any changes that would be for the Medicare physician fee schedule, that's going to come out on or about July 1st. That allows the next 60 days for congressional review, and then the final rule comes out on or about November 1. Now, I will say that the MIPS program has been coming out in a separate rule. So if you'd like to be a geek like me, you can go to reginfo.gov, and that's where the information will be posted for you. So if you want to see when that goes over to the White House to review, that's when it would go. Last year, I want to say it did come out in March. So this might be some time where, we need to start looking for the rule on reginfo.gov. But again, it's one of those, we'll see what the White House does and also what latitude they feel they have under current legislation. So with that, I'm going to go ahead and open it up for questions and see if anybody has any. I do actually see a couple in here, so let me go open that up. Oh, great. That's a question about the 90-day signature item for Stark. So let me go quickly back to that, and so let me zoom through here and get back over to the Stark component. Obviously, the best horse's mouth on all of these things are going to be the actual section in the law, so love for you to go and check that out. But I did highlight and copy and paste this. So it's 90 consecutive days immediately following the date in which the arrangement became non-compliant. So basically, you have a 90-day window. Once you realize something becomes non-compliant, that you're going to have a 90-day window to get that signed. Now, one of the interesting things and where the lawyers are going to have to go is that the statement is where it became non-compliant, not when they became aware of it becoming non-compliant. So that awareness and knowledge, that's what's called mens rea, is going to be a really interesting component as we look at the compliance for this. But this does give some flexibility. Again, things for you to look at, things for folks to be aware of, and I'm sure there's going to be a ton more coming out. Remember, too, that technically this will need to go through rulemaking. While it is law at this time, it's not necessarily part of the code. Therefore, I would anticipate this to come out in the Medicare fee schedule, which means that truly it will be effective later this year or beginning next year. So let me go double check if there are any other questions. I believe that was the only one that we had right now. The question follow-up is signatures on what? So this is going to be signatures on any of the compensation agreements for physicians. So for example, on a compensation arrangement, let's say that this is a physician compensation arrangement between a hospital and a physician. And let's say because the physician, for whatever reason, signed an agreement that allowed them to get paid for the number of x-rays that they were ordering. X-rays are considered a designated health service, and if they do not personally perform the x-ray themselves, meaning the full component of it because they're billing the global, that would be a non-compliant compensation arrangement. So this is a subsection of the Stark Law that is one of the areas that does have a carve out, and it's very prescriptive of what can be in a compensation arrangement. So it would be basically anything that was found to be non-compliant, you would have 90 days from when it became non-compliant to create a new agreement and get signatures. Typically, what I believe this is going to was when there were new agreements that were put in place and there was new amendments and everything else, but they were done unilaterally to make those changes, meaning that the physician's signature was never obtained. This here is saying that those signatures do need to be obtained. So again, for history on this one, I would direct you to the Office of the Inspector General for some of their statements about signatures on these type of compensation arrangements. So with that, I'm going to go ahead and zoom to the end. This was a longer than 15-minute, but I love that you've stuck through it with me. We have a number of upcoming events. Love for you to participate in those, or if you have any events that you'd like us to hold, please, please, please let us know for both the live webinars and also the Give Me 15-minute videos that we post on our YouTube channel. I highly recommend too that you go and check out the video archive on our YouTube channel, which is titled Give Me 15 Minutes. If you're watching this video archive, please also be sure to rate it because that does help us on whether or not what we're providing to you is helpful. Also, if you're attending the live version, please take the quick survey at the end of this webinar. It helps us improve these sessions and create timely, valuable educational responses for you. The last thing too is that you can sign up for notices about the Give Me 15-minute programs and our blog and other items that can all come to your email. So I highly recommend that you do that. But in the meantime, I hope that you have enjoyed this session, that you've learned something new about this archaic and crazy world of ours. It is strange days on planet Earth for sure. But I also hope that you are going to give us some great feedback on sessions that you would like to have in the future. So thank you very much for participating in today's Bipartisan Budget Act of 2018's overview, and this concludes the presentation.